next paper is entitled Epidemiology of Pancreatitis, and the presenter is Dr. Rebours.
So, excuse me, the topic was changed because it was not appropriated to the session. So I propose to change and to talk about cystic lesion. And it's my pleasure to talk about and to try to compare the new European consensus guideline for cystic lesion and the international guidelines to know if it's better to...
By the way, bravo, thank you.
to manage our patient. So why is it so important to have some guidelines for cystic lesion? Here you can see an overview and see that we have a lot of guidelines. We were published since many decades, and the two last guidelines was from international guidelines in 2017, and very recently the European one. Is there any interest, and what could we have to do when we have some patient with cystic lesion? So first I want to confirm that it's a main issue for every gastroenterologist. As you can see here in huge German population studies, they find more than half of the patient you can find some cystic lesion, but they consider cystic lesion with a size more than 2 millimeters. But the frequency and the incidence of cystic lesion is very high, and when we look to the different data, we can see that usually there are between 1 and 5 lesions, but the main issue is that they are less than 1 centimeter in more than 90% of the patient. So when we look to the evolution of this kind of cyst, we can see that the prevalence and the size of the cyst will increase with time and the age of the patient, and more than a quarter of patients will have an increase of the size of the lesion and the number of the lesion in a follow-up of 5 years. So what is exactly the diagnosis of the cystic lesion? Here is the distribution of the patient we see in out-clinic patient in the hospital where I'm working at Beaujon Hospital in France. And we can see that more than 80% of patients came from IPMN, around 5 and 6% of the patients came from mucinous or serocystenoma, and a few patients came for cystic neuroendocrine tumor, solid pseudopapillary tumor, or acinar cell cystadenoma. So the main issue is that some are precancerous lesion, IPMN, and mucinous. That's why probably we have so many guidelines we were published to try to manage this kind of patient. So here I will try to compare these two different guidelines we were published more recently. And I will first begin by serocystenoma. We know very well that it is a benign lesion with an unknown prevalence, very frequent in females. And usually the diagnosis is very easy by imaging procedure. It's a single lesion with multiple cysts, usually a central scare and calcification with no wall enhancement. So the diagnosis is not usually a problem. And in this retrospective international cohort study with more than 2,600 patients, we found that the outcome shows only 3 serous adenocarcinomas with a related mortality rate less than 0.1%. So it means that for the European guidelines, that it was the same for the international guidelines. It's important to achieve a complete workup to have the right diagnosis, but then after serocystenoma have to be with a conservative management, I mean no surgery, and follow-up is only required if you have some uncertain diagnosis. For mucinous cystadenoma, as I told you just previously, it's a precancerous lesion with no communication with the main pancreatic duct, usually found in women. And we don't have any right criteria to confirm a high risk of malignancy. Here it's an Italian series published by a radiological team, and they find that if you have more than 3 or more of this kind of criteria, the risk of cancer is very high. And it was a size more than 7 centimeters, presence of septa in wall thickness more than 3 millimeters, a number of loculation more than 4, presence of nodule, of course, metastasis, of course. But when we look to the literature, there is quite only surgical series. And in this series, great series with more than 163 patients, when we look to pathological results, we can see that more than 76% of the patient had only low grade of dysplasia, and retrospectively, probably that more than 3/4 of the patient could not have some surgical resection, and surgery could be avoided. So the patient who had adenocarcinoma had nodules or papules, and the median size of the lesion was more than 4 centimeters. So it's probably time to change the paradigm. That's what experts propose, and the international guidelines propose surgery mainly, but follow-up for some patients with comorbidities. But they propose formally surgery for lesions more than 4 centimeters, patients with symptoms or mural nodules. For the European guidelines, they propose some surveillance for patients with a lesion less than 4 centimeters with no symptoms, I mean no acute pancreatitis related to the lesion, and no nodules. They propose the surveillance with at 6 months and every year MRI or EURS or both, and patients have to be fit, of course, for surgery. So now we have to propose surveillance probably for patients with mucinous cystadenoma, as we did now for IPMN. So for neuroendocrine cystic lesion, I will be very fast. You know that usually it represents less than 20% of pancreatic neuroendocrine tumors. It's a well-differentiated, usually tumor grade 1. And in this very recent series with more than 263 patients with cystic PNETs, they found that malignancy were diagnosed in more than 15% of the patients, and the risk factor of malignancy were age more than 65, a size more than 2 centimeters, the size of the main pancreatic ducts, and of course imaging features with positive nodes. So what the European expert proposed surgery for lesions more than 2 centimeters, but surveillance for lesions less than 2 centimeters with no symptoms, no sign of malignancy, and lesion grade 1. It means that we have to propose biopsy for patients with this kind of lesion. It's exactly the same recommendation as the INET Society proposed for solid pancreatic neuroendocrine tumors. They did not make any difference regarding the fact that it was a cystic or solid tumor. There is no specific recommendation by the international guidelines we were published. Just to finish, and it probably the more difficult, it's for IPMN. As you know, why we have to propose some surveillance is the risk of cancer, which was around more than multiplied by 15 regarding the general population. And what it is very important to know is that even if probably nothing appears during the 5 first years, the risk of cancer is still there after 5 years of follow-up, as it was greatly demonstrated in this great series. I mean, the risk of malignancy within 5 years was 4.3%, but after 5 years it was 5.5%, and the risk of invasive cancer after 5 years was still more than 4%. It means that probably we have to continue to follow this kind of patient, even if it's not perfect and guidelines are not perfect. Here is the guidelines we were proposed by the international group of experts. You can see that they propose first time high-risk stigmata of malignancy and worrisome features that I show you. I know that you know them very well. What they changed in 2017 is that they propose for worrisome feature nodule less than 5 millimeters, lymphadenectomy, rapid rate of cyst growth more than 5 millimeters every 2 years, an abrupt change in the main pancreatic duct caliber with distal pancreatic atrophy, and elevated serum level of CCR99. So did they write proposing this kind of criteria? I think we can say probably yes, because in this series from the Mayo Clinic, we can see that a patient with no worrisome, no high-risk stigmata, the risk of cancer at 5 years is very, very low, less than 2%. And in case of worrisome, we have a risk of cancer more than 5% and a risk of cancer in case of high-risk stigmata around 50% at 5 years. So when we try to see what proposed the European expert, did they change anything? I think that probably the more important is that they propose some relative indication for surgery. It's quite exactly the same as worrisome features. But they propose newly diagnosed diabetes, and I think it's probably important because, as you know, diabetes could be a pre-symptom of pancreatic cancer. And they propose a size more than 4 millimeters, and it was 3 centimeters for international experts. So here, you can see that in case of absolute indication, one or more, they propose surgery and then a follow-up. Of course, if your patient is not fit for surgery, you don't have to propose any follow-up. In case of relative indication for surgery, it means quite worrisome features. They propose if there is one or more than one criteria with no comorbidity surgery. In case of 2 criteria with comorbidity surgery. But in case of 1 criteria with comorbidities, they propose a follow-up every 6 months by MRI or AURS. And in case of no indication of surgery, they propose the first year, every 6 months, clinical and radiological follow-up, and then after 1 year, every year, until your patient is fit for surgery. You can see the difference is that they did not make any difference regarding the size of the main cyst. They did not propose a different type of surveillance. So, and to conclude, the cystic lesions guidelines we can see are absolutely not perfect because there is too many issues. We have to select it patient we will develop pancreatic cancer, and we don't have still biomarker which are very specific for now. So probably what we have to understand, no cyst without an accurate diagnosis, that's the first point. It's important to achieve a complete imaging workup, including CT scan, MRI, and endoscopic ultrasonography if you have some doubt regarding the diagnosis. No surgery without an accurate diagnosis, no surveillance without an accurate diagnosis. And if we need, we can perform EUSFNA, enhanced contrast EUS, new endoscopic tools as Cellvisio, for example. And the main point is that probably pancreatic cystic lesions are not an emergency of care, so we have time to have a multidisciplinary discussion. So thank you very much.
Maybe I can get us started in questions. If I understood correctly, your MCN recommendations, I understand you were concerned about the 76% that you had that were low-grade dysplasia in that group that were resected. I appreciate that attention to the burden of overtreatment, which I think is a critical feature. But in trying to operationalize that into a prospective surveillance strategy for MCNs, it sounded like lesions that was a, lesion that was a 3.8 centimeter MCN in the body tail would be committed to surveillance under these recommendations. I have a little bit of a concern about that because if that's a lesion in the body tail of a 30-year-old, we know that if we look as age progresses, the likelihood goes way up for malignancy. So I would have to sort of be reassured that our surveillance criteria will be stringent enough to be able to detect a change so that we get that at high-grade dysplasia before malignancy.
Yes, you're right. I think we have all these guidelines. As I told you, we don't have right and accurate criteria to know about dysplasia and so on. And we have to balance what they propose regarding age of the patient, the type of surgery you have to propose. It's clear that a young woman with a lesion in the tail and a resection quite easy, and if we know that we have to propose a surveillance for, I don't know, 20, 25 years, we won't have exactly the same strategy that with women already age 60 or 70 years old. So
Sure.
Absolutely.
Yeah, I think that makes sense.
Carlos?
Great presentation. I think you did a beautiful summary, and some of the concepts are novel. I liked your slide, the last slide, but I want to challenge you. So, no surveillance without accurate diagnosis. So the reality for you, for us, is that in the majority of these patients, because we're seeing these patients with very small cysts, we presume they're branch duct IPMS, but we don't know that. That's not an accurate diagnosis. And while you could posit that you would do endoscopic ultrasound and biopsy, we know that that's not always going to be the answer, nor always the right thing to do, right? Because very small lesions may be harder to sample and complicate. So I like it. I would love to have a definitive diagnosis in every patient that we follow. I also, as a surgeon, will say that if something needs to come out, and it's clear that it needs to come out, even if I don't have an accurate diagnosis, do I really want to do an endoscopic ultrasound and biopsy? We might disagree on that, right? Like from the gastroenterology standpoint or from the surgical standpoint, but perhaps not. And I think Kim puts a very good example, right? So a mucinous neoplasms, if I see a woman who's 35 or 40 and has, a 3 centimeter cyst in the tail of the pancreas, well, I know statistically that's going to be a mucinous neoplasm. Even if I do an EUS, I'm not going to get a definitive diagnosis because it could still be an IPMN, right? Because I can assume that it is maybe on morphologic reasons, but I might recommend for that patient a laparoscopic distal pancreatectomy now as opposed to watching it for the next 40 years. So do we have a definitive diagnosis? No. Are we following the guidelines to say no? So this still continues to be an art more than definite guidelines. But I loved it, and I very much liked it.
Thank you very much for your comments. I completely agree with you that what I show you first studies is that mainly patient came with a lesion less than 1 centimeter. And sometimes we have to do with, we know that it will be very difficult to know if it is a little serocystenoma or probably mucinous or so on. So sometimes when we don't know, and we balance between benign and potential precancerous lesion, we propose surveillance. And of course, regarding the evolution, sometimes we thought that it was probably the first diagnosis and we change with the time and the evolution. So I agree, we cannot have accurate diagnosis for all of patients, and in this case, we have to be cautious and to continue surveillance for this kind of patient. And as we talked just previously, we have to moderate this kind of guidelines. Myself, I do a mixed between all these guidelines. I do my own salad or sauce, I don't know how to say that, because we have to balance regarding age, comorbidities, type of surgery, and it's clear that I propose resection surgery for young women. I know they have a very high life of expectancy, and I won't propose surveillance for many, many decades with a risk potential of malignancy, of course. So, thank you.
We applaud the work. Thank you.
I've got one question. Sorry, I just can't resist. So for someone that follows the international consensus guidelines, with some caveats. I noticed on your slides that you said that, that mural nodules less than or equal to 5 millimeters are essentially a relative indication for surgery. I speak for many in the room who I think would be uncomfortable not operating or surveilling a patient with a mural nodule of 4.9 millimeters, let's say. I wonder if you have any information or can qualify that point more about the size of mural nodule as correlated with the degree of dysplasia or invasive cancer.
So what it's important, I think, and to assume is that it is not mucus and it is a real nodule. First, I think that c'est probably why they propose this change, because when it's very small, less than 5 millimeters, it's not so easy sometimes to distinguish some mucus and some neural nodules. So as we talk for mucinous, I think if you have a real nodule less than 5 millimeters and you know that it's not mucus, for very young people, I think that probably we can balance and manage and propose surgery for this patient. Another point that it was not mentioned, but I think it's very important, is that we have to interview a patient to know regarding their familial past history and pancreatic cancer, because we have also to balance what we propose between surveillance or surgery sometimes, if there is one, for example, pancreatic cancer history, first degree or second degree, even if it's not pancreatic familial cancer history, sometimes we won't manage a patient if there is one pancreatic cancer in the family and a precancerous lesion. We don't have any criteria for this kind of patient, and that's probably the main issue, I think.
Thank you.